I have one more question about RFA and surgery. Because this is something I ask a lot of doctors, and I'm curious where you stand on this. Do you believe there's ever a case where you could simultaneously do surgery and RFA on a patient? Say they need to have one side removed, and then the other side, to preserve it, they treat something on that side with RFA.
Yes. So, in fact, that patient I told you about, 3 RFAs.
Mm-hmm.
My proposal for him was we would take out the enormous half surgically and treat the other half with RFA. That would have been my preferred approach. I'm a big proponent of that idea. I'll tell you another one, and I haven't talked to a lot of folks about this yet, but it is something that we're looking at with a few patients. Sometimes they have these great big goiters, and they're so big that there's more surgical risk.
Right.
Okay. Because that nerve that we try to protect runs right underneath the thyroid. And typically you sort of rotate these things up, but sometimes that nerve is stuck on the backside.
Mm-hmm.
And as you begin to rotate it up, it gets stretched if you don't realize it's there. And the bigger this is, the more risk of it being stretched before you can even get to where it is to free it up. Could we use RFA to take an 8-centimeter thyroid, reduce it down to a 4, and then do a safer operation for benign disease? Could we take one that's wrapped all the way around the back of the esophagus, shrink that down by RFA, and then do a safer surgery to remove the bulk of this, right? And I think that approach will have some real applications, again, in certain situations. So to answer your question, I do think there is a role for RFA, even when surgery might be inevitable, to make that a safer surgery instead of having to deal with this enormous amount of goiterous growth. So the biggest one that I've ever taken out was 18 centimeters on a physician from Sri Lanka. And she wasn't very tall. And so this thing was into the chest and up underneath the jawbone. And it was just a massive operation. Some of those that are down into the chest, could we do RFA on the upper part and then have a safer surgery?
That's what I was going to say. Yes. In those cases where you have the substernal component, that's what happened with mine. Part of it was substernal, about 20%. So the first RFA caused that substernal component to move upward. And so in a case where you have someone with super massive nodule that's probably never, ever going to be able to have enough RFAs to shrink that, RFA might be a good way to debulk that mass.
You know, one thing to understand when we're talking about substernal, the thyroid is attached up here in the neck. So when it grows down below the clavicle, it's being pushed down because it can't bulge outward because it got underneath the clavicle. Inside the chest, we have these lungs that are pumping all the time, right? And so if it's able to, that motion will push that back up into the neck. Shrinking the upper part by RFA, that part is always going to be pushed up, okay? It's always going to be pushed up because that's what the motion of the lungs and the heart moving around inside your chest is going to do. It's going to slowly push it up, provided there's relief of the stuff that's up here.
Right.
Right. So the largest substernal that I've ever taken out was 12 centimeters below the clavicle.
I can't even imagine how that patient must have felt.
Well, it was even pushing on the heart, and we had a cardiac surgeon standing by in the room in case we had to split the chest open to get this all out.
You get that all through a neck incision?
In that case, we did, yes. We have a nice picture of this on the MRI where it's just filling the whole chest.
My goodness.
And we did get that up and out, but you could have had life-threatening bleeding in that case. If we could have debulked the upper part and let that come up slowly, I think that would have been a safer option for her. But of course, RFA didn't exist at that time.
Yeah.
But I think we might see the advent of some of those applications where we can reduce surgical risk by debulking or shrink with the RFA technology.
That's very interesting. Very cool.
Yeah, it's very exciting. It's another tool in our toolbox. You know, as a surgeon, that's what I love to have. I love to have as many tools as I can and to be able to use them for some of these unique situations that our tools weren't that great for.
Mhm.
So having a cardiac surgeon standing there at the bedside ready to open up a chest,
I'm sure that took the
that's
pressure off of you.
well, the thing is, the pressure was on because if we wouldn't have got one of those vessels, then he would have had to get in there in a hurry.
Yeah,
Getting a safer operation is always a win for both
definitely.
patient and surgeon. Yeah,
Absolutely. You
yeah,
want good outcomes. I mean, that's why you do this. You want the patient to have a good outcome and a good quality of life. And in cases with thyroid cancer, you want a cure. You don't want this person to be passing away from thyroid cancer. And
yep,
that's why we're having this conversation right now.